this is high. Then if we'll go to inflammatory biomarkers like proalbumin, patients have higher prealbumin level, globulin level, so those patients labeled for ARDS. And if we'll go at the end of the table, the patients have D-dimer is high, means that this patient labeled for high probability for ARDS. Then this is one of the findings they found in their studies, that those patients who receive steroids, they have better outcomes than those patients who didn't receive steroids, and we'll discuss later. So they conclude this finding. Among the 200 patients, 40% of those patients develop ARDS, and the mortality among those ARDS patients about 50%. If patient have dyspnea on admission, he has multiple comorbidities like diabetes or hypertension, they are liable to develop ARDS. Then mortality is high among old people more than 65. Patients have neutrophilia, or patients have any organ anticoagulation dysfunction. High-grade fever correlated with ARDS, but not correlated with this. And people who receive steroids has decreased, has a more survival rate more than patients with non-ARDS. Then this is our valid definition of ARDS, which is Berlin definition. We all of us know that ARDS should fulfill 4 criteria. First of all, acute onset of bilateral lung infiltrates associated with hypoxemia. Hypoxemia is defined as the BF ratio. If BF ratio less than 200, less than 100 means that patient have severe ARDS. Between 100 to 200, patient have moderate ARDS, and between 200 to 300, patient have mild ARDS. BF ratio is arterial VO2 over the oxygen concentration you are giving to your patient. So this is the 4 major criteria we are diagnosing, and of course, we have to consider that those patients may have cardiac element and give the same picture of ARDS. So it's better to assess your cardiac function to rule cardiac element either by echocardiography or depending on the history of the patient. He developed, for example, anteroseptal MI, then have picture of hypoxemia, bilateral lung infiltrates, going with cardiogenic pulmonary edema more than ARDS. Then this is very tricky question nowadays. Is really COVID-19 pneumonia fulfilling the criteria of our ARDS or no? And of course, this is study run by Gatatuni, which is famous name for ARDS. He found that ARDS of COVID-19 is completely different from regular ARDS. All of us know that the main pathophysiology of lung of ARDS is decreased compliance. There is poor correlation between volume and the pressure of the alveoli. So what we all know that ARDS means decreased compliance of the lung. But Prof. Gatatuni mentioned that there is different types of ARDS for those patients with COVID-19. And one of the main characteristic features that patients have severe hypoxemia and they have relatively respiratory mechanics. It will be very familiar to you that you will find your patient is saturation late 80s and he's maintaining good respiratory rate, good tidal volume, even he's not tachypnic, not distressed. And he classify the ARDS of COVID-19 into 2 types. First type is this one. This is characteristics by patient to have ground glass appearance, usually in the peripheral part of the lung. And you'll find that the patient is maintaining good aeration area, lung volume of those patients are maintained, and patient has well aerated area. So those type 1 patient is not need for recruitment maneuver because they have good area of aeration. And the pathophysiology of type 1 usually it is endothelial injury, which means that those patients with endothelial injury, they have lack of vasoconstriction of pulmonary vasculature secondary to severe hypoxemia. In spite, the lung parenchyma will be maintained apart from some ground glass appearance at peripheral part. And this ground glass appearance is a reflection of subpleural edema, distributed subpleural edema. Type 2 is similar to our typical form of ARDS, that patients have too much atelectasis, too much area of consolidation area. Patient have a big lung volume because of patient have well-inflamed and edematous lung, and the area for gas aeration is less. And this lung, of course, will be responsive to recruitment because we have more area of atelectasis and consolidation. So Gattoni, they say that ARDS in COVID patient is not typical ARDS. It classifies into two types. First type, we mentioned, can be means that it is L type, which means that patient have compliance of lung. And type 2 is H type, which means patients have low compliance, and those lung special type 2 liable for better recruitment and responsible for recruitment maneuver. So which type our patient will go? Yeah, it will be type 1, that patient to have good compliance, or type 2 patient have poor compliance. It depends on the severity of infection, the immune response for the patients, and how your patient responds to ventilatory parameter you are setting your patient, and how his response to oxygen concentration, and of course the time of presentation to the hospital. So it depends on severity of infection, immune system of the patients, and how he will be responsive to your treatment, and of course the time of presentation to ER. Then if we go to discuss the details of type 1, the patient mostly have normal compliance, and he has low amount of non-aerated lung. The main pathophysiology of hypoxemia for this patient is ventilation perfusion mismatch, as we mentioned, because of endothelial injury would be reflected on the hypoxic vasoconstriction response of pulmonary vasculature. Lung weight of this patient are light because there is no inflammation and less edema. Then the lung, because of most of the alveoli are well aerated, there is no room for recruitment for those patients, and usually those patients have mild respiratory symptoms. In spite of hypoxemic, who will have respiratory symptoms. So this is type 1 or L type. Type 2, which is similar to our typical patient of ARDS, which label at H type. Patient have low compliance from increased edema. Patient have, of course, right to left shunt, will add more to ventilation perfusion mismatch. Because of too much edema and inflammatory mediators, the lung of those patients are heavy, and of course there is area for good gas aeration. So there is a lot of collapse or atelectatic alveoli, which can be responding to both pressure or recruitment maneuvers. It usually represents 25 to 30% of cases presented for ARDS. Then sometimes patients started by L type to H type, which means patients started by normal compliance, and after some time will progress to H type. It depends on, of course, the progress and severity of the disease. Maybe normal progress of the patient start by good compliance and only ground glass batches, then we'll do complete the full picture of ARDS because of progressive disease. But we have another mechanism why patient progress from L type to H type, which called patient self-inflicted lung injury. All of us are aware by the term by ventilator-induced lung injury, which means that patient ventilator may induce atelectatic trauma, volutrauma, biotrauma, oxygen toxicity, and those patients may develop worsening of ARDS because of ventilatory parameter. But this patient usually he started by his spontaneous breathing, especially with L type, he has good compliance and he has less respiratory symptom. So those patients, because they have their work of breathing is high, so they have increased intrathoracic pressure. So this negative intrathoracic pressure associated with increased permeability of the lung because of the inflammation, it will lead to more edema, increase of lung weight, more atelectasis, and decrease lung volume for gas exchange, and will end by decreased compliance. So patient started by L type, which means that he has good compliance, and by complete picture of ARDS, which H type because of self-inflicted lung injury, and of course maybe normal progress of the disease. Then this is summary again. If we go to L type, patient have high compliance, level of ventilation perfusion scan ratio, sorry. Patient have low lung volume, and patient have low recruitability. In comparison to H type, patient have low compliance, patient have more ventilation perfusion mismatch, patient have high lung weight because of edematous lung, and there is room to response to oxygen therapy or recruitment maneuver for those patients. Then assume we have one patient, the area has already hypoxemia, and they diagnose him as COVID pneumonia, and is fulfilling criteria of ARDS. So this is the simple algorithm how to improve oxygenation for this patient. Usually we start by simple oxygen therapy by nasal cannula, face mask. So then we have many non-invasive maneuver before going for invasive mechanical ventilation. We'll start by high flow nasal cannula. We have non-invasive mechanical ventilation or CPAP. Patient is not responding, we have invasive mechanical ventilation. Then patients not responding, we'll go to rescue therapy, which include proning position and ECMO service. So start by simple face mask, nasal cannula, then we have non-invasive maneuver like high flow nasal cannula, CPAP, plus put in with this non-invasive awake prone position. Then patient is not responding and is worsening, we can proceed for invasive mechanical ventilation. Not responding, we'll go for one of the rescue therapy prone or VV ECMO. Then this is our protocol of how to manage COVID pneumonia and how to manage ARDS. Then you will find this protocol in the file of all COVID patients, and this is simple algorithm you can review by the end of lecture. We'll share to the group. Then we'll start by high flow nasal cannula. One patient will come to your either ER or hospital, then he's not responding to your regular nasal cannula or face mask, and the patient still tachypnic, distressed, and started to be desaturated. But patient still have room, he's not fulfilling the criteria for intubation. So you can apply for him high flow nasal cannula, that this is the gas source. Then you will give pressure from 40 usually to 60 centimeter water. Then we have humidifier to give more modification of your high flow oxygen you are giving to your patient. This is a nasal bronch you are giving to your patients. So how high flow nasal cannula will improve condition of patient of COVID pneumonia? First, because you delivers humidified oxygen, and this humidified oxygen, of course, will decrease the airway inflammation, maintain mucociliary function, and improve mucus secretion. This is the first part, because you apply humidified oxygen to this patient. High flow rate will, of course, it will decrease the work of the breathing of your patient, because it matches the patient demand. Usually decrease the dead space and provide positive pressure in the upper airway. So maybe consider like you apply some PEEP for your patients. So this is a mechanism, and simple mechanism why high flow oxygen improves the respiratory function for those patients. There is a lot of trials about high flow nasal cannula. The first famous trial is Florali trials, that if you apply high flow nasal cannula for those patients, they found there is no difference in intubation rate. But there is a lot, there is systemic review, meta-analysis of 9 studies, they show that high frequency nasal cannula reduce intubation rate if you compare to conventional oxygen therapy, but of course it didn't affect the mortality of those patients or length of stay. So this experience of high flow nasal cannula in SARS before, patient and 50% of those patients develop respiratory failure, and 20 to 30% of those patients admitted to ICU, and 33%, 1/3 of those patients, they applied high flow nasal cannula. they found that high flow nasal cannula avoided intubation about 34% of patients in Hong Kong. Of course, this high flow nasal cannula, you should of course observe your patients well. You should ask him to wear his face mask. And of course, this high flow nasal cannula, of course, less aerosol generation than for non-invasive mechanical ventilation. Then the recommendation for high flow nasal cannula for COVID-19 patients, they should be used for patients with hypoxemia if conventional oxygen therapy is failed. And of course, it's far better recommended over non-invasive mechanical ventilation. And the most important for any non-invasive procedure for improved oxygenation, you should observe your patient well, because those patients not responding, you should be ready to intubate him at any time. Second part of non-invasive way to improve oxygenation of your patient is non-invasive mechanical ventilation, either to apply CPAP or you can apply BiPAP. And this is usually our face mask, and this is our circuit. But look here, what is different from other non-invasive circuit we are using for regular patients, that we have here HEPA filter that it will be acted to filter the exhaled volume from this patient to decrease the aerosol generation during exhalation process. Of course, if you apply non-invasive for your patient should be in negative room. Patient try to choose the best fit mask test for him. And you should observe your patient regarding his improvement, regarding oxygenation, blood gas, pattern breathing, and keep your threshold of low of your patient. So to go for conclusion of the use of non-invasive mechanical ventilation in COVID-19, that routine use of non-invasive ventilation for those patients is not recommended because it's liable for spread of infection among the healthcare providers. Then it should usually it is associated by high failure rate, and patient, of course, most of physicians prefer not to intubate those patients because it will be induce more high risk for them. But of course, it may lead to delay intubation and more bad consequences, especially we are delaying intubation. Patient maybe have severe hypoxemia at the time of intubation with cardiac arrest. So don't wait so long for those patients to non-invasive mechanical ventilation. Once you think to intubate this patient, you should intubate him. Then patient, as we mentioned, he should be in negative pressure room. And of course, you should have a clear plan if it's not improving by non-invasive mechanical ventilation, keep yourself standby for intubation. But we shouldn't consider it is part of the standard management because of high risk for spread of infection. Then there is another way of non-invasive way to improve oxygenation before go for intubation, that you can apply prone position for your patients. And there is still few studies, especially for COVID-19 patients. This is one of those patients, they apply him for prone position. Then they checked the BF ratios. They found once you apply, once you put your patient prone position, there is improvement of BF ratio. Then you put him supine again, then BF ratio decrease. Then this red arrows, this is a time of application of putting your patient in prone position. But here, patient, we start to put him in prone position, but he didn't respond because he has to have some nasal congestion and because of position. So once he cleared his nose, he started to respond again to awake prone. This is our protocol in King Saud Medical City, and we applied for the whole cluster. This is how to apply awake patient with COVID-19. It's different from the prone position for intubated, ventilated patients. We'll discuss later. Here, the duration usually, you can keep your patient from 30 minutes to 2 hours. Then you can check his response regarding his respiratory rate, regarding oxygen saturation. And of course, there is a criteria you should exclude before applying This procedure, patient should be conscious, oriented. He can able to clear his secretion, hemodynamically stable. He don't have any facial injury. He don't have any fractures. And of course, pregnancy should be avoided. Then you need every now and then to assess the response of your patient regarding his oxygen saturation, regarding his respiratory rate. So sure, you will find this protocol in the file while managing those patients. Then we'll go again. So you failed by high flow nasal cannula. You may try non-invasive, but I personally prefer don't try. Then you try to apply patient awake proning. Then patient is not responding and is start to be worsening of his FO2 requirement, is more tachypnic, desaturated, worsening of his X-ray. So you want to intubate this patient. Remember again that this ARDS patient is different from regular ARDS of other reason. So we have two types. We mentioned that we have L type, and L type, if we remember, it means that this lung of this patient have very good compliance. So if the patient have had good compliance, so we don't have more alveoli will get benefit from recruitment maneuver. So those patients usually need lower beep than regular ARDS patients. And if you know, usually apply low tidal volume for ARDS patient, and for better lung protection, usually apply 4 to 6 ml per kg, but we can accept higher tidal volume for this patient. Then, because if you apply low tidal volume, patient may have decreased tidal volume, and patient have more retaining of CO2 because of increased dead space, and it will be compromise the ventilation perfusion mismatch. So you shouldn't apply lung protective strategy for this patient, that you shouldn't apply low tidal volume, and you shouldn't apply high B for L type. Then we'll go for H type. H type, if you remember again, this means that this is typical ARDS, that compliance of lung is very poor. So we have room for recruitment. So those patients who have high tidal volume 4 to 6 ml per kg, you keep plateau pressure target less than 30. Then you can use higher beep, usually from 10 to 15 centimeter water. And if he's not responding, you can put your patient in prone position during this time. And of course, this low tidal volume strategy, those patients liable for more retaining CO2 and permissive hypercarbia, which should be accepted. For the better of lung protection. So we should accept the pH of 7.2, 7.18 for the sake of the lung protection, because applying low tidal volume strategy, it will improve the outcome for those patients. Assume your patient is not responding by regular mechanical ventilation. Patient now in high ventilatory setting, FI2 is high, BF ratio is very low, and the patient is worsening. So it's time to think about another maneuver, how to improve oxygenation for those patients. We have a lot of way to improve oxygenations for those patients under the name of rescue therapy. Rescue therapy include prone position, include high frequency mechanical ventilation, include ABRV mode, include high frequency, include the ECMO service. You should keep your patient use of muscle relaxant boluses or muscle relaxant infusion. You can apply recruitment maneuver, like you increase your beep 40 centimeter water for 40 seconds. All of this under the name of rescue therapy. And of course, we shouldn't forget nitric oxide, which show some response of this patient that it causes pulmonary vasoconstriction, but we don't like to use because it has no evidence base that improve oxygenation, improve outcome except for a short time. And those patients, they have rebound hypoxemia once you stop giving them nitric oxide inhalation. Before going for rescue therapy for ARDS, we should assess your patient, which means that this hypoxemia may be related, of course, to progressive ARDS, but maybe a lot of causes, and there is room to improve those causes before going for rescue therapy. Which means, for example, patient have poor cardiac function. that patient, you should assess his cardiac function because may have left ventricular failure, left ventricular dysfunction. So you should optimize the function of the left side of your of the heart of your patient by giving your patient an inotropic hemodynamics unstable, or you can start ACE inhibitor, diuretics, small dose beta blocker, which all lead to improve the left ventricular function of your patient. The opposite can be fine, that your patient maybe is hypoxemic, not because of he's overloaded, maybe because his intravascular volume depleted. Because most of our ARDS patients, we are giving them Lasix to keep them negative. We decrease the IV fluids we are giving to them. So those patients, if they have severe intravascular volume depletion, it will be compromised. The cardiac output will lead to ventilation perfusion mismatch because of low cardiac output status. So this patient, you may channel them by fluids, and you can assess your vascular volume state of your patients. Then third reason that your patient may not be improved, that he may have a right ventricular dysfunction, which is common among ARDS patients. Some of them, they have right ventricular strain, right ventricular dysfunction. So we should optimize the function of the right ventricular of your patient by giving inotropes in the form of dobutamine or inodilators like amiodarone according to your clinical assessment for your patient. Of course, don't forget that your patient should be well sedated, give him muscle relaxant, and you should treat other causes like infection. So if you are correcting these causes that improve the right side of the heart, left side of the heart, maintain intravascular volume status, your patient is well sedated and is on muscle relaxant, so you have to start your rescue therapy. Of course, the most acceptable rescue therapy for ARDS in general and for COVID-19 is prone position. So how prone position will improve oxygenation of ARDS? First of all, it decreases ventilation perfusion mismatch, it will help to drainage of secretions. And if we look here, this is patient here in supine position, that if we look to the weight of the heart is already resting on the lung tissue, which will lead, these areas will be attenuate and collapse. But if you prone your patient, the weight of the heart of the patient will be on the sternum. So there's no pressure on the lung volume. A lot of explanation, but this is considered to be the most valid theory how prone position improves oxygenation. And by the way, it is evidence-based that proning of a patient of ARDS will improve mortality. It is a study under the name of PROSEVA study that they found that mortality decreased from 33% to 16% on 20 days of hospital admission, and after 90 days, mortality increased from 41 to 24. So there is evidence-based that prone position improves oxygenation of your patient. But of course, before proning your patient, there is certain point you should be sure. First of all, you should be ready with your team. Usually we need 6 persons to prone your patient. One will be take care of the airway, tubes, central line, then 2 persons on each side of the patient, and one will at the level of legs of your patient. Then after proning before proning, you should maintain the intravascular of your patient. You can even start electively small dose inotropes or vasopressor to maintain the blood pressure, because once you prone your patient, will lose the compensatory sympathetic mechanism. So this patient should be intravascular volume maintained, and you can maintain some vasoconstriction to maintain their pressure. Once you prone your patient, of course, you should check the pressure point in forehead, eye, chest, abdomen, genitalia, then check his upper limbs not to be overstretched for possibility of brachial plexus injury. Usually we maintain our patient prone position for 16 hours. Then we check the response regarding the FiO2 requirements, the BF ratio. Then you should put your patient supine again for 8 hours. So if your patient is not improving on prone position, you can use another rescue therapy for them, which is maybe you can call for ECMO service. If patient is not improved, you should call the ECMO service, and put in your mind the contraindication for ECMO. So any patient have severe coagulopathy, patient have severe thrombocytopenia, patient, of course, you consider that his terminal stage, patient have terminal illness, you shouldn't apply for ECMO, because ECMO service is you will not find in every institution, and of course the cost, it is very high, and you should keep for selected patient who expected that he may get benefit from those. This is a ventilatory part of management of ARDS. Then we'll go to non-ventilatory part, which include steroids. Steroids, of course, in medicine is a matter of debate, and of course of ARDS, there's a lot of debate about use of steroids in patients of ARDS. Then this is meta-analysis for the study using of steroids in ARDS. They found there is no settled conclusion. Either ARDS patient will get benefit from using steroids or no. They don't have conclusion. It was era in the early 2000, especially when Midori, he ran a lot of studies, and then he support the plan of giving steroids for ARDS patient. But many studies after a few years shows there is no improvement of outcome for those patients. So it's a matter of debate. Then they tried, this is meta-analysis for studies tried for viral ARDS. Whatever the etiology of this viral ARDS, they found patients receive steroids, they have high mortality rates than people who are patients who didn't receive steroid. And this is a direct evidence about role of steroids in COVID-19 patients. The test done for about 90 patients in Wuhan, they found that in 200 patients, they found that a patient who received methylprednisolone, they have better survival than patient who didn't receive steroids. This is our own experience in King Saud Medical City for H1N1 at 2009. We found that if we give steroids to our patients, mortality about 50%, and the patient who didn't receive steroids, it's about 30%. So in our data about H1N1, that steroids increase mortality about 2 to 3 times for patients with viral pneumonia second through H1N1. Then we'll go direct to the recommendation for mechanically ventilated patient, and he has COVID-19. And ARDS, they suggest to give systemic steroids. But of course, still matter of debate, because there is still low evidence, and if we'll check the studies, they support this recommendation. It was over 200 patients. So why is people said it's better to wait for more randomized controlled trials, but it's still matter of debate. But they suggest you can give your patient steroids. And usually we can use the steroids, a patient, for example, unstable hemodynamics, and you consider a septic shock and they have adrenal insufficiency. So you can give your patient steroid. It will be part of hemodynamic support, plus maybe a part for management for ARDS. But they said we shouldn't use corticosteroids if patient have COVID-19 and has respiratory failure without ARDS. So we shouldn't use except if patient have ARDS. Then this will be summary for the management for COVID-19 with ARDS. If patient have mild ARDS, we should apply low tidal volume 4 to 8 ml per kg, then blood pressure less than 30. Then if patient you consider is not improving, can think about bacterial infection, can add empirically antibiotics, keep your target 90 to 96. And of course, the fluid management of patient with ARDS is matter of debate, because the more you keep your patient dry, the more will be intravascular volume depleted, will compromise the renal profile, and those patients liable for acute kidney injury, and they may need to start for them CRRT. As we mentioned, systemic steroids matter of debate. If patient have moderate to severe ARDS, we can consider to increase your PEEP. You can give your patient neuromuscular blockades. Then you can do recruitment maneuver, apply 40 centimeter water for 40 seconds, then prone your patient for 16 hours. You can maintain a muscle relaxant infusion, then you can again try steroid. Then if patient failed, you have a rescue therapy, which include prone position. You can use nitric oxide, and you can refer your patient to ECMO service. Thank you so much, and I hope I cover most of the aspect of ARDS in COVID patient. Thank you. Any questions?
Looks like everything is clear.
MashaAllah.
We have a question here, Omar, about any study about high frequency in COVID?
I come across a lot of studies to check the rescue therapy. None of them studied about use of high frequency in those patients, but we should avoid, because high frequency ventilation, it may be increase the possibility of more aerosol generation, and those patients liable to contaminate the room and people be high risk for infection. So in general, we should avoid in those patients with viral pneumonia in general, but there is no studies for time.
The place of hemodialysis in H4 cytokine removal. I think we can point this question to Dr. Muhammad Audet. He can answer that next lecture, inshallah.
So,
okay. MashaAllah.
I don't know whether L type or H type, what parameter to use.
H type, he want to comment about it, which is actually reasonable. Yani. L type is not, there is no place for that, but H type was cytokines and another question, if not known whether L or H type, what parameters to use, I mean, of mechanical ventilation?
For L type and H type is not a difference about the mode of mechanical ventilation, but the important is the target. Usually for H type, usually you'll apply regular mechanical ventilation for ARDS that apply low tidal volume, 46 ml per kg, and plateau less than 30, then you can accept higher beep because lung compliance is poor. But L type, the lung compliance is good, so there is no need to maintain low tidal volume and no need to apply high beep, because the main difference between both types is the compliance. One type of good compliance, the other type with poor compliance. Then there is question, what about awake proning? How many minutes? Usually apply from 30 minutes to 2 hours according to patient response. And then you can check your respiratory rate and oxygen saturation. Then you can rest your patient supine, then you can put him prone again according to your patient response.
No more questions, Shabab. MashaAllah, you have so many thumb up for all your friends from the group. From the ICU, yes. Shaneem, Nada, all of them.
Thank you.
عندك شعبية كبيرة والله دكتور ما شاء الله.
ماشي يا حكيم، تسلم ايديك.
Any more questions شباب؟ Okay, thank you so much for this.
شكرا حكيم. السلام عليكم.
Very good, you are saving time. Or that online or Muhammad, we can call him to join early. Dr. Adat is around?
Just wait, Doctor.
Dr. Intikhab asking about we don't have high flow nasal cannula here. Yes, I agree with you. We have, no, but almost when I did ask the RTs, he said we have almost 8 machines now and the processing to purchase many of them. So I hope we can have most of them sooner. Do you think is there any difference in proning? We have questions in the WhatsApp group. Omar, you are still with us?
ايوه حكيم موجود.
طيب اعتقد في على اليوتيوب وفي على الواتساب جروب.
حكيم.
خد على الواتساب جروب الاول.
قول.
في عندنا سؤال من do you think is better, is there a difference in proning effect between L and H type, early and late?
They didn't discuss the difference between Bron and both types. But of course, if you have to choose which patient you should apply, we should apply, of course, for each type because you expected those patients have more area of atelectasis and they have room to improve oxygenation by improve ventilation perfusion mismatch. Of course, Bron position will do the job in all types, but of course it will give a better effect in H type because more area of atelectasis, more area of consolidation, and more area of ARDS. So the main difference, you can differentiate between L type and H type by the CT. And once you intubate your patient, you can check by the compliance of your patient in the mechanical ventilation. You find your patient is compliance is low, means that he's H type, and if compliance is high, means that he's L type. So this is the main way how to differentiate between both.
Okay. We have from, I think, also Dr. Intikhab about the non-rebreather mask, but the availability of the high flow nasal cannula, you want to say. Not available in place of non-rebreather mask are used. Can we use? I think yes, we can use non-rebreathing mask, what we have now available. But he said we don't have high flow nasal cannula. There is no clear questions. How to avoid coughing? In place of how to avoid coughing.
Where?
In case of mask, if you are using mask, and how to avoid coughing?
Mask for patients or for me?
In case you are using, for example, high flow nasal cannula or using a non-rebreather mask, which is oxygen support before intubations, and how you avoid coughing to avoid spreading of the.
Hello.
Right. So this one, I have. Do you have comment? I can comment this.
لا comment يا حكيم.
Actually, coughing, it is difficult to avoid in the patient is awake, but in the patient during extubation, you can use some sort, and I will touch it in extubation procedures. You can use some sort of narcotics of dexamethasone or cough suppressants before you extubate your patients. But I can tell you that Chinese experience, they have two management for symptoms, which they said it can decreasing the progression of the disease. One of them is antibiotic or controlling of fever, one of them controlling of cough. And they have in the China specific transdermal patch. They said, I don't know what the content of this one, which can controlling cough. And from their study, they said, controlling cough and fever, it can minimizing the severity of the COVID-19. But use anti-cough depressants in patients awake didn't assist for the awake patient in the COVID-19. Lidocaine, yes, lidocaine nebulizations, it can be this good option. Actually, we have COVID-19 with us, but lidocaine, one from the option you can use before extubation, and you can use before intubation even to decrease the stress response. It's very common actually between anesthesiologists and it's test to be used, and still valid for minimizing the stress response and the cough response before extubation and before intubation. It is present when we can use awake proning position. When we can use awake prone position.
Can be tried.
Dr. Omar, yes.
Awake prone can be used if you apply, even you can, awake prone position, you can apply for patient with nasal cannula, with face mask, with high flow nasal cannula, and some studies to apply non-invasive CPAP. So if your patient is not responding to regular oxygen therapy, including high flow nasal cannula, you can try for him awake proning before proceeding for elective intubation. So be considered last option or one of the options before going for mechanical ventilation.
Thank you. The talk about lidocaine nebulization. I think you remind me with anesthesia, and all of you, and maybe you are familiar more than us with the lidocaine nebulization, right? What I remember, you can comment actually. It can be used to minimize stress response, but I think if not irritant, and I think the concentration has to be 4% or something like that, and it can induce itself if your patients, or for example, you can use it in fiber optic intubation. You are familiar with that. I think we can hear from you, COVID-19. If you can unmute your mic and you can comment. Yes, IV 1.5 milligram per kg would be easier, but nebulization is a little bit risky for the patients with the COVID. Maybe we can use. Kohel, you can help me to unmute Ahmed. You can unmute Dr. COVID-19.
For who you
can hear from him.
دكتور for who؟
احمد سلام.
اي دكتور اي دكتور
سامعني؟
ايوه تفضل.
We can start.
لا الدكتور علاء استنى دقيقه واحده بس. Just a while. I just one comment from one doctor. Dr. COVID-19. I can unmute him. Yes. I like to hear your comment
He's
about.
Unmuted. You can comment.
Yes. Doctor. Your mic is open. You can use it.
It's there.
Doctor. We have to deal with cough, but not delay intubation. Yes, I'm agree with Dr. Babu. Dr. COVID, he cannot hear me, I think. Dr. Abu Azim, he mentioned intubation should be done in negative pressure room or in the room with HEPA filter. It can be. It's better to be negative pressure room, of course. And this one will be discussed in the intubation and the procedure, the last lecture. Okay. Before and after extubation. Still again, nebulization. I think Khalas, he was not on the line. Thank you, Dr. Omar, so much. Now we have more message. Yes, nebulization. Yes, very, very important point actually. Nebulization should be avoided to prevent hospitalizations, which is very valid point. We will discuss it also in hospitalization genetic procedures. A bit difficult to be avoided. So IV only can be used in such situations. Thank you so much for your contribution. I don't know we have question on the YouTube. No more. Only Dr. Bilal is commenting. Dr. Omar, thank you so much. We can go for Dr. Audet. Yes, it is ready. You can start.
Good evening, everybody. My name is Dr. Mohammed Al-Audet. I am ICU consultant in the KCMC. Actually, my presentation will be two parts. The first part will be we'll discuss the convalescent plasma as treatment of COVID-19, and the second part will be discuss a plasma exchange, therapeutic plasma exchange for COVID-19 patients as a salvage therapy or rescue therapy. Put the first slide. As we know, there is no specific treatment for COVID-19 until now. So there is multiple clinical trials trying to find a new treatment to be safe and effective. And one of these trials, a convalescent plasma, promising to be used as a treatment for severe cases of COVID-19. So what's the mean of the convalescent plasma? Is a liquid portion of the blood taken from someone who recovered from particular disease, which contains antibodies helping to fight with an infection. And people who recovered from the COVID-19 have antibodies to the disease in their blood. This is the definition of the convalescent plasma. Next slide. No. Is it a new this using convalescent plasma or no? Of course, it's not a new. Convalescent plasma was studied in a previous outbreak of the respiratory infections, including the SARS-1 in 2003, H1N1 2009, 2010, MERS 2012, Ebola, hemorrhagic fever, and in H5N1. So this is not a new treatment. They tried in a previous respiratory infections with outbreaks. So this, as you can see from this slide, convalescent plasma therapy for the treatment of the COVID-19 virus
عليكم السلام ورحمة الله وبركاته. ازيك يا حكيم؟
لا
اخبارك؟
الاخبار
كنت بدي محاضرة يا حكيم بقى فاني
Please put the slide. As we, why you are hurry? Wait, Ahmed. Put the first slide. First slide, the picture, the immune cells and antibody virus. Still, I will talk about this slide, please. Okay, fair. Okay, this slide. As we can see from this slide, the convalescent plasma therapy for the treatment of the COVID-19 virus infection is based on the function of the antibodies. Some of the antibodies can neutralizing the virus, while other work by mobilizing a range of the other immune cells that fight of the disease. So these two types of the antibodies, one of the antibodies will neutralizing the virus, another will mobilizing the virus in the immune cells. Next. This the ELISA they are using to determine if the blood does actually contain antibodies specific to the virus. Blood is collected from the patients who had a PCR test positive, now the test is negative, of course, and we are doing apheresis. We are separating the serum and the red blood cells, and we are taking a serum plasma, and we are thinking this plasma will contain antibodies against the virus. Next slide. The components of this the virus, known as antigens, are placed in the testing well. As you can see, this is the number one. The antibodies from the patient serum will bind with antigen if present. If there is antigen, the virus is present, and there is a signal antibodies. This is the second antibodies introduced. The signal antibodies bind to the virus antibodies, which is called signal binding. And at the end, we will found positive signal confirmed presence of the antibodies. So this the sixth will be the confirms there is antibodies against the virus. Next. Once the COVID-19 antibodies are confirmed, plasma contain antibodies. The convalescent plasma that can be bind that can be bind and kill the virus of uninfected patients that does not yet have immunity to the virus. So this will be convalescent plasma ready to give the patients infected with COVID-19, which is that not yet have immunity to the virus. So we are using this convalescent plasma from the recovered patients to give a patient infected with COVID-19 to help him to fight the virus. Next. It is the COVID-19 treatment. A lot of multi-clinical trials are underway, with some showing promising results when convalescent plasma is used to treat severe cases of the COVID-19. However, the convalescent has not yet been approved by the FDA as a treatment option for the viruses. It's still investigational product. So this only for investigation. It's not definitive treatment, and is not yet approved as a definitive treatment. Only this is a trial to help for patients in severe condition with COVID-19. So all the trials, until now, this is not a definitive treatment, only trials. So when next, who is the patients we can give? The condition, the most important, this patient's laboratory supposed to be COVID-19 positive, so confirmed COVID-19. And you have to check for the patients. Of course, you have to take a consent from the patients, and we will give the patients of life-threatening disease, respiratory failure, septic shock, multi-organ failure, and this severe COVID will be patients with, you can try it with severe patients with COVID-19, patients with short to suppressed respiratory rates, tachypneic, and desaturation if PO2 of IO2 requirements less than 300. So this is ARDS with bilateral infiltration within 24 hours to 48 hours. So any patients with met this criteria, we can give a convalescent plasma for him. Next slide. Now, from the donor of the patients, also there is a condition we have to check. These patients, we have to take a consent from the patients. Of course, like any blood product, we have to check for the transmitted infections. This is must be to rule out the HIV, hepatitis B, hepatitis C, and all the infectious diseases we have to rule out. Of course, there is evidence of the COVID-19. This patient is supposed to be the PCR negative. He had an infection before. The IgM will be negative. The Ig titer will be positive by ELISA antibodies, which was we explained what's the ELISA antibodies to check the IgG for the COVID-19. So if the high titer will be better. Of course, the patient is supposed to be, the donor is supposed to be asymptomatic 14 days after recovery. So this is after the recovery, 14 days. So you will take the blood sample from him after 28 days. 28 days. The female donor can be, but not pregnant. Of course, male and female, but the female donor is supposed to be not pregnant. And the antibody titers you have to measure, and 1 to 160 and more. And if more, a lot of studies, there is 1 to 1,000. So if high titers is preferred if high titers. Next, as you can see from this, the antibodies IgM and IgG the IgM will be in the acute phase and will disappear from 21 days, in the 21 days. And the IgG will start from 14 and will be the maximum titer will be on the 28 days. 28 days. So the PCR will be negative, the IgM will be negative, and the IgG titer will be high in 28 days. So the best to take the donor to take from him the plasma on 28 days. So patients may have had a past infection and has recovered from the COVID-19. This is the donor we will give the patients. Okay, next. So the convalescent plasma transfusion indication, of course, supposed to be critically ill patients, the age more than 18 years old and above, confirmed COVID-19 with PCR, and patients on life-threatening condition we are using as a salvage therapy or rescue therapy. And the criteria, the symptoms will be more than 1 month, ARDS, sepsis, decrease of conscious level, multi-organ failure, and patient with cytokine release syndrome. And we will discuss the cytokine release syndrome in patients with the therapeutic plasma exchange. And the criteria also, the labs, you can use the interleukin 6 to measure ferritin and elevated the D-dimer. Next, please. So this is the first study, was 19 patients, and the outcome of this study was very good. Was improved the oxygenation symptoms, radiological and viral load, 1 to 7 days, within 1 to 7 days. Patient requiring ventilations, ECMO also could be weaned. This patient was in ECMO, and after the patient received a convalescent plasma, weaned from the ECMO. In this study was no deaths, and the patient was stabilized and discharged with no significant adverse effects. So this is the very good outcomes from this study. And they use 200 ml and 300 ml and 400 ml. Another study, they use only 200 ml single dose, and I will show you later. And they measured the neutralizing antibody titers, convalescent, and this neutralizing antibodies increased after the patient received a convalescent plasma. So this is a very good outcome from this study. And this study, if you can see, also they use as a prophylaxis, but we are not using. We are using only for life-threatening patients with multi-organ failure or severe cases with ARDS and so. But in this study, they use as a prophylaxis and a therapeutic. Next slide. This slide will the summary for all the presentation. This the donor, how to the criteria for the donor, the criteria for the patient's eligibility, who the patients will receive the convalescent plasma, also the guidelines they put, how to give, how much, when you will give, and how you will monitor the patients. And you can this slide will summarize all our presentation. This is taken from this study with 19 patients, which was the very good outcomes. Next slide. This another study, and they use a single 1 dose, only 200 ml of the convalescent plasma, and was significantly improved and neutralizing antibodies with high level, and leading to the disappear of the virus. in 7 days. Also, the clinical symptoms was improved, and radiological also was improved radiologically. But still, this need to be in randomized trial. And this patient in this study was on 10 patients, and also the outcome was good. But they use convalescent plasma for rescue therapy for severe patients. This first part, I finished the first part. If any question, and we will answer at the end of the presentation. The second part of my presentation will be about the anti-cytokine storm targeted therapy. This is the plasma exchange in the patients with COVID-19. The next slide. The hypercytokinemia, which is called a cytokine storm, is frequently a feature of severe infections with the SARS, MERS, H5N1, H7N9 influenza, and also this is the features of the COVID-19, and this is the predictor of the mortality if the patient develop a cytokine storm. And some studies showed that the cytokine and chemokine clearance was achieved using such as plasma exchange, therapeutic plasma exchange. Next, the cytokine storm. If you can see the virus, this is COVID-19. The patient will be infected. This is the reaction of the patients. Will be released the pro-inflammatory mediators, which is the cytokine, chemokines, interleukins 2, interleukin 7, interleukin 10, and all this pro-inflammatory will damage the organs, which is the heart, liver, kidneys. And if this pro-inflammatory will damage the heart, the patient will develop myocarditis, so will develop heart failure and liver failure and acute kidney injury. Of course, will damage the muscles, and the muscles will release the CPK, and the CPK also will myoglobulins will injure the kidney. So our target, and this all process will goes to the death. So this is the patient will develop multi-organ failure. We can see from this picture how the cytokine storm will affect all the organs, and this will lead to the multi-organ failure and death, of course. So our target to break this cycle, and we are trying to use the therapeutic plasma exchange to clearance all these cytokines from the body, and the cycle will be goes to the recovery, to the another cycle. So this is the idea from the plasma exchange. It's not a treatment of the virus. This is the treatment of the cytokine storm, and this therapeutic plasma exchange was used in multiple diseases. Still, this is under trials. So this is the main our targets to break this cycle and remove all this cytokine from the body. Next, the therapeutic plasma exchange is used for cases where the plasma of the patient has harmful immune materials like autoantibodies, the cytokines, and it has been maintained as an effective treatment of the cytokine storms. So the therapeutic plasma exchange we can use for cytokine storms. This is the main idea from our trial to use plasma exchange. Next slide. Next slide, please. Next slide. Next, class. Next slide. Right. Okay. In 9 April 2020, the FDA they approved to use Optia apheresis system to treat the patient with a cytokine storm. With a patient 18 years old and above and confirmed COVID-19, patients with multi-organ failure in ICU, in respiratory failure, and we have to we have to concern the safety and the potential effectiveness of the treatment. So this we are using our machine. This is our machine to remove all the cytokines from the body. According to the FDA, this is for the trial only, not for treatments. Next. And this is the criteria to use the TPE, therapeutic plasma exchange. The first of all, supposed to be COVID-19 positive, the age 18 and above, patient with respiratory failure or any of the following: acute lung injury, ARDS patients, patient with severe, of course, he will be dyspneic, respiratory failure, more than 30 per minute, blood oxygen saturation will be 93%. VO2 ratio will be less than 300, and with lung infiltrates and with life-threatening diseases like respiratory failure or septic shock with multi-organ failure. This is the criteria. The patient, we will check the patients if he is a candidate for therapeutic plasma exchange or no. Next. So the treatment for patients with COVID-19 infection who exhibit a cytokine storm and rapid progression of the disease, and this will be confirmed with lung imaging, with bilateral infiltration, with X-ray or CT scan, X-ray or CT scan. Then next, and this is the first case we did in Al-Imam Abdul Rahman Faisal. This is first case was done in 11 April 2020, yani after 2 days of approved from the FDA to use therapeutic plasma exchange as a rescue therapy or a salvage therapy. Next, please. And this is the case. We have a patient with a 51 years old Bangladeshi patient. He previously healthy, not diabetic, not hypertensive, was admitted to the hospital with a diagnosis of COVID-19 positive pneumonia and ARDS. The X-ray was bilateral infiltration, patient intubated, mechanical ventilated. On CMV, FiO2 was 100% with PEEP10. So this is the type phenotype H with low compliance. This patient was ARDS with low compliance. The ratio was, the VO2 ratio was 181. So this was a moderate ARDS. Patient was sedated with RAS-4. The heart rate was 102. The blood pressure was maintained on inotropes, was in NORAD 0.1. And the saturation was 98%. The hemoglobin was 10.9. D-dimer was 6.3, and lactate was 1.7. So this patient, according to our criteria, was candidate for therapeutic plasma exchange, and our plan was to do 5 sessions for these patients with albumin. And the first session was done at 11, and the second session was 12. Third session was 13 April 2020, and patients start to improve on the third session, this session clinically and laboratory and radiologically was improved. This patient start at the third day. The FiO2 was 40%. VO2 improved, and all the parameters was improving. and we decide to do another session, another 2 sessions. Was done on 14 and 15 April 2020. This patients at 18 April 2020, patient was successfully, alhamdulillah, extubated and was hemodynamically stable, and the patient was discharged to the ward on room air at 2020 for 2020 with this parameters was, this patient was, the parameters was, everything was improving, and patient was successfully discharged to the ward. Thank you. I finished my presentation. If any question about the convalescent plasma or plasma exchange, I'm happy to answer it. Thank you.
Thank you, Dr. Oded.
Any question?
Wallahi, they look like they understanding everything.
Understand everything. Okay. We have now in Abdulrahman Faisal 2 patients on plasmapheresis, and in our hospital we have 2 patients also. A third one, I think, in KCMC was died. But until now we have 4 patients. On another 2 patients, alhamdulillah, also successfully extubated and sent to the ward. I talked with Dr. Fahid, and another 2 patients was, so we have 3 patients successfully, alhamdulillah, treated with this salvage therapy. But until now, this is only for trials, and this is not a definitive treatment, of course. This is only, we are trying to save the life of the patients with this method of the treatment.
So Muhammad, we have a question related to the hemodialysis earlier. Hemodialysis for the latest stage of ARDS, which is the H type of ARDS.
H type of ARDS, I prefer the early dialysis. Early dialysis, and also to remove the cytokine, we can use a cytosorb. Also, we have a patient improved. We put him only in the Xyrus filter, to remove the cytokine. Also improved. So I prefer to do the early dialysis. If a patient is not indicated for dialysis, you can do to remove the cytokine. You can use not CRRT, not to remove the fluids. If you want to remove, you can remove fluids. If we want to remove only the cytokines or the urea, creatinine, you can use to help the kidney to work as acute kidney injury. So the CRRT I prefer early CRRT.
We have another question on that from Intikhab. We have to use albumin or FFP?
Albumin. We all the patients we are using albumin. As you know, this is the recommendation that came from the Optia and from the ASCA. The only you will use the FFP if there is coagulopathy. If there is a coagulopathy, we'll use the FFP. Otherwise, use the albumin as replacement therapy and as plasma exchange. So use the albumin.
For convalescent plasma, they did ask each recovered patient from COVID-19, how many patients can give as convalescent plasma? Can he give?
That recommendation. One of the study they took from the one convalescent plasma from one recovered patient, 800. But you can take 1 liter convalescent plasma, and you can give for 5 patients. But this is according to the titer. If the titer high, you can give single, single dose, 200 ml, single dose. If the titer low, you can give 200 BID or 300 or 400. Even there is a study 500 they give in divided doses. This will depends on the titer of the IgG titer. If the titer more than 1 to 160, you will use 2 doses. But if the titer 1 to 1,000, you can use 1 dose, 200.
Do you have any patient? Did we use convalescent plasma? I don't think.
Until
yet,
now, we are preparing. No, we don't have.
But we have donors already, right?
Dr. Fahd, he's preparing 20 patients, recovered patients, to take from them as a donor, and we will start, inshallah, soon to give to start as a convalescent plasma as soon, inshallah. Yani 20 donors. Dr. Fahd, he's preparing the.
Dr. Thamer asking a very difficult question. He asked if there is antibodies formation by the patient, why reinfection is reported?
Huh?
Dr. Thamer, the head
this is not reinfection.
Yes.
If the criteria to take a donor supposed to be PCR negative twice negative to be sure this patient recovered, and the IgG high titer.
The general question, he said if the patients recovered, the patient already developed antibodies. Why selected cases reported of reinfection for the COVID if already have immune? So why? Actually, Dr. Thamer, the reinfection is not yet decided by the WHO it is clear or not, and the very few selected cases, which is not until now. But the China report, they said there is immunity for such case, but the immunity, yes. You have comment on that about this one? Immunity.
Yes, there is no reinfection until now. This is
yes.
South Korea also they found this is only there is no reinfection. This is the same microorganisms with same infection. They found positive twice. It's not recovered. This patient the same. It's not reinfection. It's not reinfection.
Yes.
There is immunity, and the immunity will be if there is IgG. There is immunity. So that's it. Yani this patient recovered from and he will not develop again reinfection. He has immunity.
Last question, we can take it from Dr. Pablo. If there is any rule for convalescent plasma to avoid the progression of the disease, yani ARDS from moderate to severe like that.
Until now, we are using only for salvage therapy, and I show you the criteria. We are choosing the patients with multi-organ failure, respiratory failure, ARDS patients, yani, as a salvage therapy to prevent the progression. Until now, no data. They are trying to use as a prophylaxis. One of these studies, 19 patients, and they didn't mention for the prophylaxis. All they mentioned about as a salvage therapy, patients improved after the patient received convalescent plasma with multi-organ failure only. So to stop the progression of the disease, until now there is no data.
Yes. Dr. kept commenting, so patient with immunity can move around.
Sure.
Yes. Dr. kept commenting, if the patient recovered already with immunity, he can move around.
Yes, he can move. He can move. He can move, but yes, he will be
nobody can guarantee actually.
He will be immunized.
Theoretically, yes.
And if South Korea also they mention because there is no reinfection. It's not reinfection. It's not the patient developed infection. No, this is false positive. Was false positive. Then the patient became negative. So this is not a new infection or so the patient who immunized. Okay.
Asking about any study comparing, Dr. Muhammad, comparing the convalescent plasma versus interleukin 6 antagonist in severe diseases. I don't think so.
No, I didn't. I don't.
It didn't come on. And by the way, all of these novel modalities, for most of the very eminent guideline, they recommend it for clinical trials. Nobody.
Yes, clinical trials. I mentioned.
Yes, nobody recommending any modalities as a high recommendation or even moderate recommendation. All of them, they said most of them, it is as a clinical trial. You can use it as a clinical trial.
A clinical trial and for severe patients, for severe patients, not for the. It's not a treatment. It's for the salvage therapy. You can try it. Maybe you will help the patient. Still, until now, there is a multiple and several trials, but still, this is under investigation, and this is not a definitive treatment, of course.
Thank you, Dr. Ahmed. Dr. Taha, he replied to you, Dr. Intikhab. He said, of course, if the immunity of the patient disturbed back or the virus mutated, so of course, you don't have the free to move around even if you have immunity from the virus. If your immunity change it, or if the virus have mutation, which is logic.
We don't know, but I until now, it is immunized. But of course, you will not roam around.
Yes. Thank you so much, Dr. Adel. Now the time for Dr. Ibrahim Suleiman, he's ICU consultant and head of our neuro ICU in King Saud Medical City. He will present actually the most, let us say, the summary of the protocol or the pathways, algorithms of the protocol of the patient in COVID-19 cluster, which is already approved and already in the portal system of the institutions. So welcome, Dr. Ibrahim. Are you around?
Assalamu alaikum.
Alaikum assalam wa barakatuh. Hi, boss. How are you?
Alhamdulillah, Allah yasalamat. Just I will share.
Share, please. Yes, okay.
Screen. Just. أعتقد you need to able me to participate. Sharing.
Okay, sorry.
It's disabled from your side.
Sorry.
Dr. Ibrahim, already you are co-hostess.
Thank you. Is it clear for everyone?
Yes,
yes, clear. Yes, thank you.
Assalamu alaikum and good morning now for everyone. Tonight we will this short talk about the critical care COVID-19 protocol, and that's actually probably the sum of a lot of things you heard during your the presentation over these 2 days. First of all, I want to thank everyone from the co-authors who participated with me for this big efforts to release such kind of protocol that we hope it will make things easy for everyone and clear for everyone. Dr. Madi, Dr. Basim, Dr. Fahd, Dr. Nasser, Dr. Balahmar, Dr. Shahzad, Zohdi, Al-Fatih, Bashir, Louis, Bobby, also Christine. Also, I want to thank Dr. Harsi for his initiative to start doing this protocol actually. And we hope this is a preliminary draft, and maybe there will be some fine edits in the before releasing it in the system with the signatures. So this is just a brief and a quick introduction. We will not go through the things that already has been lectured already before. We will go through some of algorithms that not yet already discussed before. So it is this standardized ICU protocol in managing suspected or confirmed COVID-19. It is a local guide with the best practice recommendations. So everywhere with this pandemic, all the society and WHO and everywhere recommending every area or every country or every medical facility.
Kindly mute your mic. Thank you. Continue, Ibrahim. Sorry.
It is for everything. There is no clear, strong evidence-based recommendation for sure. So it is the best practice recommendation from all the different quality of evidence we can get, and it is liable to be updated whatever new evidence is coming through. So the protocol will be, as you can see, starting with introductions and operational definition, then guide on the scope of and purpose. I think a lot of these things has been discussed, including admission criteria and diagnostic workup, laboratory and diagnostic imaging. Also, BOCUS. You will find some guidance for doing it, and respiratory support. This is actually done just tonight, and we will continue doing the protocol for respiratory management of COVID patients. And also, you will find a guide about tracheostomy and hemodynamics. In addition to criteria, the things that Dr. Odad just finished with convalescent plasma. And then you will find the pharmacotherapy chapter that has been discussed by Dr. Bashir. And then you will find the documentation or implementation tools, which are the daily checklist, daily practice checklist, which includes a bundle checklist for the best practices that everyone, physician and nurse combined, should go through it. Some tasks for nurse, some tasks for physicians, and they need to make sure every day that all this best practice has been done, and if not done, has been justified. Including SAT and SPT and sedation, delirium plan, DVT prophylaxis, GI nutrition. So it is just like a reminder to don't miss all this important best practice. Tubes, lines, drains, revision for need and restraints to continue or not, and mobility and pressure ulcers and the patient family communication. And the last thing is the code status need to be addressed or not. Also we'll find the BOCUS reporting form, including the 12 areas of the lung ultrasound, addition to cardiac focused echo, and the 2-point of DVT venous scan of the lower limb. After that, you will find in the protocol the appendix. This appendix contains the clinical algorithms, which are really concise and targeted pathways for you. This protocol, we will discuss it tonight, the COVID-19 ventilation protocol. And the guide for prone position of awake patient of COVID-19 with steps and inclusion-exclusion criteria. And then you will find in the appendix a guide for proning, the usual proning for intubated patient, including around 12 chapters for everything about prone. This for the general ER-DS patient, then need to be applied with addition of PPEs and all precautions that are new for a COVID-19 patient, suspected or infected one. Then this need to be modified for a COVID protected environment. And also you will find the anticoagulation pathways that discussed by Dr. Bashir last night. So we'll start with the indication of intubation. This table already, you will find it there in the appendix. And I will go through this 6 indications. So just for you to know, this is not a solid criteria. It is just a recommendation for you as a clinician. The idea behind this is to take the decision of intubation of COVID-19 suspected or infected patient ahead of time, electively ahead of time, to avoid crash intubations. The problem with crash intubation is this will lead to a very high risk of viral transmission. So if you are loose with taking decision regarding intubation, you may be pushed at 3 o'clock in the morning to intubate such kind of patient as an emergency intubation. We don't need this scenario at all. Try to avoid doing this emergency intubation because it is life-threatening for the patient and also threatening the team with an infection. So try to keep this ahead of time. So we have this recommendation criteria, starting with number 1, including the saturation less than 90 to 92 on FiO2 0.4. We select 0.4 because, as you know, the liters per minute can different from the way you are giving to your patient, with either it is by nasal cannula or by simple face mask or by non-rebreather. So the fixed concentration is FiO2. So FiO2 0.4, whatever you are giving, as with nasal cannula or by face mask, and this should be included with the high work of breathing. We'll go through why we selected these numbers and what we need to define the high work of breathing. The work of breathing, we defined it here as any of this respiratory rate more than 30 breaths per minute, obvious accessory respiratory use, and paradoxical breathing. We will discuss while that sometimes it is difficult to get an idea about the real work of breathing with only the simple measures, but this is the only available or the only visible for us in our environment. But the classic thing and the best thing is, or accurate, is the esophageal balloon. So putting esophageal balloon for COVID patient still a risky procedure, and it is not available everywhere. So we have to go clinically as we are seeing now, and then we will discuss some pitfalls for that. The second criteria is the rapid progression of suspected or confirmed disease. COVID disease, clinical with escalating FiO2 requirement. So if the patient starts to require more oxygen, escalating, and if his imaging, either chest X-ray or lung ultrasound or CT scan, has been worsening over 24 to 48 hours, 50% is arbitrary value, but still you will find the criteria number 6 will solve all these problems I will talk about later. Evolving hypercapnia was defined, it's defined as pH as less than 7.3 with PaCO2 more than 50, and in COPD patient you need to depend on the pH. As you know, the CO2 will not be helpful on those patients. Persistent hemodynamic instability despite resuscitative measures, and this is a simple criteria or general for other critically ill patients. And next is the multi-organ failure, and the clinical, and the last one is the clinical indication. Any clinical indication at the discretion of the treating physician. So you are, as a physician, you have the right to decide for your patient if even none of this criteria or some modification of this criteria for the numbers, for the percentage, or for the thresholds here. So this is will make the things flexible for everyone to decide for his patient, not a solid criteria, but it's just make some light in your way when you take the decision. Then, yeah, why we selected 90 to 92? There is a lot of debate about that, and if you look for the guidelines or guidance from everywhere, almost every country has their own guide with their own numbers. You'll find different numbers. So we will go through the evidence first, and then we'll go to the physiology. Why we selected these numbers? From the evidence, if you look for the recommendation of 2018 from the rapid recommendation by BMG. This is based on meta-analysis and systematic reviews that done 1 year before from the Lancet in the Lancet journal. And regarding the oxygen therapy for acutely ill medical patients, this guidance give you a clear things, despite the evidence here is not all through is the same intensity. So the clear thing is that you should not go clearly more than 96%. So don't go more than 96% at any time for your patient. This is risky. Hyperoxia is risky and increased mortality. And the evidence here is somewhat strong. And the included evidence or studies are somewhat strong evidence. Then they saying you can go between 91 and 90, between 90 and 92. So don't start if you are oxygen, if you are in this range, 90 and 92. And this is what we select. The evidence here is somewhat weak evidence. And there is another moderate evidence which to go at or above 93. So you can go here, preferable to go here 93. And this two scenarios with the lower limits is applied for patient with acute stroke or myocardial infarction even. So if you put oxygen more than this on such a patient with myocardial infarction, you will find the troponin getting high in these studies. So anyway, it is 90 to 92. Preferable 93. We didn't find much difference, so we selected 90 to 92. And we will come now after a while to say this is numbers are not strict, and it doesn't mean much for us. So this is the evidence for the first time. And even if you go through the recommendation from the societies or from associations, including American Heart Association, European, and British, and New Zealand, and Australian, you will find different targets: 90, 94, 95, 90, less than 90, less than 94, less than 92. So even it is different from everywhere. But even the most is less than 94, which is the somewhat higher threshold of the BTS, British Thoracic Society, is having grade D evidence. So it's an expert opinion. So at the end of this, you will not find a solid for the lower limit, but the upper limit was more than 96. This is a strong evidence. You should not go. The lower limit still you can debate about it, and most of them are almost the same. But if you go to the physiology, you will find the oxygen curve saying to you that less than 90%. If you go more than 90% of the oxygen oxygen saturation, there is no much increase in the BO2. So if the association between the FiO2 and the BO2 and the saturation above 92, there is no much benefit if you keep increasing the BO2. If the saturation reached more than 90%, it will not increase much. If you keep increasing the BO2, keeping giving oxygen, it's still the increase will be incremental because it's going to flat at the upper portion here. And also saying that below 60 of BO2, there is a stepwise decrease in the oxygen saturation. So these two magic numbers are keep saturation more than 90 and or SpO2 more than 90 and BO2 of less than of more than 60 are the two coming from the physiology here. So this is the most important for us when we're doing this protocol to select this kind of numbers. And then if you make it some thinking about that for physiology also, how low is too low here? What is the difference between hypoxemia and the hypoxia? Are we targeting the arterial oxygen only in the blood? This is the definition of hypoxemia. And or you are targeting the tissue oxygenation. The hypoxemia is the hypoxia is a failure of oxygenation at the tissue level, triggering the anaerobic metabolism. So for sure the most important thing is the hypoxia, not the hypoxemia. So if you keep the SpO2 more than 90%, Still, this is just in the number in the arterial blood or the attached to hemoglobin, making oxyhemoglobin. But still, the important thing is the tissue level or tissue hypoxia at the end, which depend on the oxygen delivery. That is having the three major components, which are the oxygen saturation and the cardiac output and the hemoglobin. And saturation is one item only, and the cardiac output or the flow is even more important than the oxygen content even in the blood. And you have to know that there is a relation between the oxygen consumption and the oxygen delivery, and this will make at the end what the perfusion or the tissue hypoxia will come or not for your patient, and not keeping only the high and or higher of SpO2, and then because you try to improve the oxygen delivery and decrease the consumption, and at the end you will find lactate either to increase if there is a low oxygen delivery, or SpO2 should rely on lactate and SpO2 better than relying only on one number. Is it 90 or 91 or 92 in the blood? At the end, this SpO2 is not associated with the tissue hypoxia. So maintaining a saturation above high SpO2 doesn't protect the tissues from tissue hypoxia. And in the other way, if it is coming lower from the hypoxia, doesn't mean that by the same time the tissue are getting hypoxemic. And at the end, we are just concentrating sometimes on the lung and forgetting the other organs, perfusion like heart, brain, and the kidney, which really need to be looked at. And if you can measure the local or regional oxygen at these areas, it will be beneficial. For example, we can measure the near infrared spectroscopy with regional oximetry or cerebral oximetry with simple machines with leads attached to the frontal area, and it can give you right and left oximetry of the brain. And so just not concentrate only on the blood, but try to concentrate on the tissues, and the important of them for sure is the brain. So at the end, we find that the number is not a big deal. So we selected 90 to 92. Then this protocol is divided into four steps to trying to define the type of the lung injury or type of CARDIS, corona-induced ARDS or coronavirus pneumonia. Starting with the step one is assess the need for intubation. Here we're trying to see if our patient really need intubation or we can continue without intubation. And then starting if the intubation will intubate, and then we'll initiate the initial ventilator setting with our targets. Then next step is to assess the lung strain and recruitability, using the driving pressure as a starting point here, and then try to classify our patient, more idea about the type of our patient, is it H or L, and then go to the third step, which is the more clear phenotype of the pneumonia. And here we will assess the respiratory system compliance, and this will give us idea about how much PEEP we are trying to use. And here is, we know clearly or most probably this type of lung or ARDS, is it COVID pneumonitis or type L, or COVID ARDS, which is H phenotype. And then we will go to the last step, which is the risk measures. If all the other measures did not get our target points, then we will go to the rescue measure. So the 4 steps we'll go through quickly one by one. So the first step is to put our target. Our target for our patient is to have a low flow oxygen therapy plus or minus awake browning. This if this maintaining the patient target SpO2 90 to 92, as we said before, with acceptable workup breathing, this is our target. So the patient like that is happy hypoxia, as in many references, and then he is already fine with requiring oxygen, but he has the workup breathing is okay. So the most important thing is to assess the workup breathing or the patient inspiratory effort. Patient inspiratory effort is a very, very vital. And you heard before about the patient self-inflicted lung injury, and this is very important. So we selected here awake proning only because we feel that it's safe for the staff mainly, and we did not put in the standard protocol other NIV or CPAP or nasal cannula, because we feel that this needs a special precautions, and they will be discussed as case by case according to the treating team. And we feel still our environment in the cluster is not ready for such a therapy, and they carry a lot of risk for the staff. Need a protected environment first, need the machine, need orientation, need a lot of oxygen supply, then actually still it has a risk of aerosol generation. And the study actually is not very much supportive for all of them, except a few evidence of high flow nasal cannula. And as you know, this has been implemented or taken from another ERDS patient. So in COVID patient, there's only 1 or 2 case reports only for using the high flow nasal cannula with in COVID patient. So still the evidence for COVID patient itself, there is not much for non-invasive, but still there is a room. If you have the whole precautions, you need to observe your patient very closely and with a short time and 1 or 2 hour maximum, then you have to decide when you are going to use this patient. And make sure, also remember that you don't use this non-invasives for patient with BF ratio less than 200. And these people usually fail. And we will talk about if the patient fail, it will be a very big problem after. So we will leave this and come back again. Why we are very cautious about the workup breathing. You have to assess and you have to know what is the status now of workup breathing of this patient or patient inspiratory effort, because as you heard about patient self-inflicted lung injury due to spontaneous breathing, this can happen either the patient spontaneously breathes or he's already on assisted breathing by NIV or high flow nasal cannula or CPAP. So it is related to the esophageal pressure swings, which is the drop from the end inspiratory esophageal pressure to the end inspiratory, end expiratory to end inspiratory. When this drop or the swing coming lower, then the esophageal pressure become more negative on the inspiratory. So the inspiratory end inspiratory esophageal pressure became more negative. So when it is more negative, the transpulmonary pressure swings will become high. So this will lead to more collapse at the end of inspiration. When it is negative pressure, esophageal pressure, the lung will get collapsed. And then with inflation, with a higher transpulmonary pressure, this will make this delta esophageal pressure, when it is high, there is a lot of transpulmonary pressure swing. This will make injury to the lung, making edema and more injurious mechanism, and will transform the patient maybe from the type L to type H or even worse. So if we have a esophageal balloon and we can maintain the delta esophageal pressure less than 10 to 20, we can maintain the patient, make sure that really the effort is good. And otherwise, we cannot do it clinically. For a patient who are already breathing okay, you find a lot of patients that crashing quickly with patient with COVID and then intubated. Probably these people has underlying patient progressive self-inflicted lung injury, and it is not noticed clinically. So just make sure that if you use these things try to avoid the huge inspiratory effort and the progression of the lung injury that will take you through to type H, and you have a problem. And the evidence showed this clearly that patient failing in IV and high flow nasal cannula burdened by increased mortality as a consequence of prolonged exposure of the injured lung to high tidal volume and patient and the pulmonary pressure swing, transpulmonary pressure swings. This is really very important. Make sure that just keep in your mind, you can use this, but if the patient fail this treatment, non-invasive, that there's a high chance that he will have, this will impact him in a very bad injury after that. He will have, likely will have a bad injury, and it will affect his mortality badly after that. Then we will continue our protocol. Then already we decided the patient if he will, before actually this we forget to discuss the COTA status, if it is really makes sense for us, age or frailty or comorbidities. It can be discussed earlier before going to intubation. If the patient will go to intubation according to the criteria, one of these, we will intubate the patient, and then we will put the initial mechanical ventilator setting. Then now we don't know which kind of lung injury we have, what phenotype. So we will give a general mechanical ventilator setting that will not endanger each one of them. We will put volume control, tidal volume 8 ml per kg of predicted body weight, and beep of 8. Rate of 15 to 20, and our targets on the left side 90 to 92, PO2 60, and this is from the physiology we discussed before, and the pH 7.3, plateau less than 30, and driving pressure less than or equal to 15. Then we have to sedate the patient with good sedation analgesia here. The patient is freshly intubated. He has neurotropism and it is difficult to control their drive. And these people really need to be intubated. If they self-extubated recently, it will be a very bad. So this patient will be sedated in a good way. And then we can use our monitor again here for such kind of patient, to addition to oximetry. Then we can use another SID line, which can give us targeted sedation with targeting the BSI. This number on the above was 36. Can give you an idea about how deep is the sedation. Deep is the sedation because there is a lot of reports about neurological injury or consequences for COVID patients. One of them is delirium due to high sedation for sure. So try to get some sense about the number of or targeted sedation. BSI less than 30 is usually deep sedation. Try to make sure that you are. And then when you win the patient, you also can use this as a guide. So now we have a monitor for the regional oxygenation or cerebral oximetry, and the patient BSI or patient state index for the depth of sedation. Okay, then we will go to the next step. So now we finish the step 1. We assess the patient need for intubation. We start the initial mechanical ventilator setting with our targets, and we're monitoring the patient for his sedation, and also maintain the perfusion, trying to assess or get idea about the brain perfusion, and in the form of regional cerebral oxygenation. You know all this every day or every lecture they're discussing type L and type H by CT scan. Okay, then this is our goal, to reach one of them by you know the mechanism, and the low, high. All this is here and there. Is everyone knows type H with low with high recruitability, and type L with low recruitability. Now our goal is to know what kind of recruitability here. So second stage here, or second step, is to assess the lung strain and the recruitability. Lung strain means the response to applied stress. A stress is the tidal volume. And so here we will try to know if the tidal volume we are giving is really stressing this lung or not. So this tidal volume is higher than what the big lung can tolerate or not. Means if there is a chance for alveoli to be recruited, then we will know from the driving pressure. So the driving pressure will be either less than 15 or more than 15. If the driving pressure is less than 15, means that this lung is there is no much recruitable alveoli, there is no much atelectating area. So then the driving pressure, the plateau minus beep, means is low, means the tidal volume stress on the baby lung is low. So this lung is usually non-recruitable, and if it, so the tidal volume we are giving is okay for this one. Then on the other side, if the driving pressure is less than 15, means the tidal volume, this one is there is a lot of stress on this lung, or a lot of by this strain, which is the tidal volume. So this tidal volume is higher for this baby lung. So means that there is a lot of areas that can be recruitable later. So what we will do, we will decrease the tidal volume to 6 ml per kg. So the left side, the lung is recruitable, and the right side is not recruitable. What we will do is decrease the tidal volume on the right side for the recruitable lung, because we need the driving pressure to come down, because it's already more than what the baby lung can tolerate. And then on the left side, we will keep the tidal volume 8 ml per kg as we started before. Then on that time, we will see how much is the BF ratio. If it is less than 150, we'll continue to the next stage. We will use a neuromuscular blocker at this stage also. And then during this time, we can use decide about our pressures and the volumes or fluids, and then do focus and for the lung and echo, focused echo. Then if you know these two types of lung injury, then the ultrasound has a lot of also correlation with the CT scan finding. So it can help us also to get some idea about the phenotype. This is the predominant features for each one. Still, it is not 100% restricted to each one of them, but it is most of the cases like that. On the type L, usually there is interstitial syndrome, and it is worsening on type H with alveolar interstitial syndrome. So when we do ultrasound at this stage, we may get more idea also supporting the CT scan if done, or what kind of lung injury. So in the interstitial syndrome, what you will see still the alveoli not involved. So mainly you will find the B lines here. B lines usually it is discrete and or confluent, but it is multifocal, focal or multifocal. So if you see the patch in the CT scan above, you find it here, find it here. So you will find the B lines here and here. So it's patchy and not attached together, and there is skipped areas with A lines in between. So this is patchy. Focal or multifocal B lines, and it is most of the time discrete, but sometimes it can be confluent. But in the other side, either progression or de novo for type H, you will find alveolar interstitial syndrome. The alveoli is involved, so this B lines will be more worse, more wet. The lung is more wet, as you can see above, right, in the CT scan. So the B lines will be confluent, and it's diffuse. So the area will take, when you scan, you will find all this area has the B lines. All this area has B lines. There is no skipped areas or spared areas in between. And the parenchymal consolidation here, compared to subpleural consolidation on the L type, here you will find more parenchymal consolidation here. Here you can find subpleural here most of the times, but here you will find parenchymal consolidation. It is large numbers, and it is continuous. It is attached to each other. It is in the same area. So this is alveolar interstitial syndrome here, and this is interstitial. So in that sense, we may get more idea once we go more. We get idea about recruitability, tidal volume adjustment. Then still the patient hypoxic, we relax the patient because we will measure the compliance after that, do ultrasound, get more idea, and then try to get idea clear about the phenotype. So here we will assess, or we know sure what is the phenotype here. Patient paralyzed to do the respiratory system compliance, and according to respiratory system compliance, if it is good compliance more than 40, it's filled on the left side with type L, which is having a good compliance. And then if no, Then if the compliance is less than 40, means we are on COVID ERDS type. Then the strategy of management here, based on this phenotype, would be for type L to continue with Brom position, because it's already, I don't have much to add here, and keep the, will not change the beep as we discussed before. There is no response for beep, there is no recruitable alveoli here. So the Brom position here will for sure will improve the VQ mismatch, and will improve the areas of the perfusion with changing the position. So for sure it will, although there is no much recruitable alveoli, but it will work here with position change to improve the VQ areas of the ventilation perfusion mismatch, to make it more even, more consistent. So the Brom position will benefit on that stage, on that type, and there is more benefit in the H type for the Brom position. So we'll use it also for 6 to 16 hours. And here, this type, based on the compliance, we'll decide for the beep. Here is a beep on the L type, we will not touch it, and this non-beep responsive. But here in H type, it is beep responsive. So we'll titrate the beep using either beep FiO2 table or driving pressure, or a lot of recruitment inflation ratio, use of gel balloon, whatever tools you have, VB curve or BV tool on the Hamilton G5. There is many tools you can assess or titrate your beep to give it, to avoid the problem with barotrauma. So anyway, this to improve the recruitability here. So this lung also can respond to a recruitment maneuver and Brom position. And as you know, that this type of L can progress to type H by time, and here the transition of the lung mechanics, we said before, it will transition from the L type with lower recruitability and less responsive to beep, and then low compliance, high compliance, to go to the other direction with the opposite way. And then still again, the ultrasound can make you differentiate, because yesterday there was a question about, when I will know that the patient will progress from Brom position, from L to H at some point. Then if you are doing daily ultrasound, then I can get this one with progression of the B lines from this type to this type. I can catch this patient probably progressing to type H. And then I may get idea with focus. Hello, are you hearing me nicely, or hello?
Yes,
yes, sure.
But if you never mind, 5 minutes.
Sure, almost done. Then stage 4 or step 4 here is the rescue maneuvers, rescue measures. Then after the previous measures, ending by Brom position on both sides, then if no response until Brom position, all these measures have some, includes the Brom position is already has mortality benefits. So we can use it as it is not a rescue measure. So the rescue measure starting from the thing is that still we don't have a mortality benefit so far, like the ECMO. So if the hypoxemia refractory to Brom position of more than 6 hours, if we use and with no response for 6 hours, then we involve the ECMO team, and then we'll decide if the patient candidate with the criteria. You can find also the criteria in the protocol as the patient candidate for VV ECMO. If not VV ECMO, then we have to review our targets and the strategy again, or we will continue with what kind of support. Then I hope everything is clear until now. We go through the 4 stages, and we pick up the changes, and we classified the 2 categories, and then we will see quickly in the 5 minutes the guide for Brom position of awake patient of COVID-19. This is actually is a simple maneuver done most of the time, most of it by the patient. It needs the patient to be really awake. So our inclusion criteria here is a patient that require FiO2 more than 28%. Again, we are going with a fixed concentration of the FiO2, not by liters, and to achieve the saturation, as we said, was 90 to 92. And then suspected COVID. This plus patient is able to communicate, and he has can rotate himself in position, and there is no anticipated airway issues. The patient will not have a problem with his don't have a problem with his airway. Without means this is absolute contraindication or relative contraindication to use. So immediate need for intubation, all the criteria we said before, the 6 criteria, like in addition to acute brain injury or unstable spine injury or abdominal surgery, we cannot bone, the patient cannot bone himself. Or relative contraindication like facial injury, morbid obesity, or pregnancy and the pressure source. Then if we have this criteria and without the third one, then we can proceed for assisting the patient to prone position. So we'll explain the procedure for the patient. We need the help of the nurses for sure and the RT around, and then ensure the oxygen therapy has been there and with basic respiratory support, rescue measures if needed, long tubes because the patient will prone from side to side, and then all this need to be secured. So we don't need to go in and out of the room a lot of times. Pillows will be needed, bed to be anti-trend Limburg, and monitor pulse oximetry or SpO2, and avoid sedation to facilitate proning here, because we don't need to really within limits, don't use sedation here. So this we will use this for 15 minutes. We are observing the patient for 15 minutes strictly, and our target to keep saturation 90 to 92 with acceptable work of breathing. This is for all our scenarios. We have our goal clearly: saturation 90 to 92 with acceptable work of breathing. If we're achieving this, then we will continue. If not, then we will make sure first that there is no disconnection or there is a decrease in the inspired fraction of oxygen. Then we can increase, or the patient need to change his position. That's why he's not comfortable, so we can change him. And if not improving the situation, then we will hold. Okay, and then we'll assess the work of breathing, because the patient, if has high work of breathing here, he may need to be intubated. So we'll discontinue if there is a high work of breathing or the patient unable to tolerate the procedure, or no improvement after we modified the oxygen and make sure that it's going to the patient. If there is improvement after 15 minutes, continue the proning procedures for 30 to 2 hours. And this is to achieve as long as the patient can tolerate up to 2 hours, it will be fine. And then when not in prone position, aim for a position of upright. Most of the times when there is no prone, then you can put the patient 30 to 60 degrees and maintain saturation, mortal saturation for 15 minutes after each position turn. The turn will go on that sequence: prone, and then on the right side, and then head of the bed sitting 30 to 60 degree or 45 degree, and then left side, and then prone again, and then repeat the cycle again. So the patient can go. If he's not comfortable in one place, we can skip and go to the next place. But at least most of the time on this circuit. This is a simple maneuver, and with it is safe for the staff at least, and then doesn't need to go in and out all the times, and there is no risk of aerosol generating. So we can use it with low flow oxygen in our protocol. I hope everything was clear, and I'm ready for questions. And thanks for our team and our first liners, nurses, and our physicians, and we hope the safe and get better for all of them that got an infection, and we hope safe for everyone, inshallah. Thank you.
Thank you, Dr. Ibrahim. Thank you so much. Very extensive and very nice lecture, like comprehensive and involving everything, even the rationales behind the protocol. Thank you so much, Dr. Ibrahim.
Thanks.
You have any questions, Shabab? Hello? Okay, we don't have in the chat room. The protocol will be available in the portal system. Here we have one question now came. For prone, do we need to put armored ETT, reinforced endotracheal tube for the proning?
I don't think, because the risk of coiling or getting depressions can get inside, it will be very bad. And there is no need to change the tube unless necessary. For these patients, don't dream for changing the tube without a really strong indication. So try to avoid changing the tube as much as you can. So we need to keep the same as the usual proning. Yes.
Yes. Actually, because of anesthesia, most of them, if any operation for the head and
Yeah.
neck, they are covering with armor tube. They prefer, but actually in ICU, we are changing it to normal
Yes.
tube without ETT, because if the
Short
patient
procedure.
kink, yeah, if he bites
Short
it at
procedure.
any time,
Yes.
yes, you're
It
right.
will be a problem. It is
will
for
be a
short
problem.
procedures, yes, and
Yes, it can be
should,
for sure. Yes.
yes, the patient should come out from OR without it. Actually, should be changed in OR ideally. Yes.
Thank you, Dr. Ibrahim, so much. I think we can proceed for the last section. I hope I can finish
Thank
it
you.
early.
Sure.
Thank you, Dr. Ibrahim.
Thank you, Dr. Ahmed. Thank you.
Allah barik. I can share my screen. Where is mine? I think this one is. We have a question, maybe. The chat room. بسم الله الرحمن الرحيم. Shall I start, شباب? We will talk about actually COVID-19 aerosolized generalized generated procedures. I think this lecture, it is almost touching your specialty as at anesthesia, and you are aware more than me in the precautions you have to take during the procedures. And most of the procedure, which is aerosolized generated procedure, is related to the anesthesia and the ICU. So we can just discuss each other and can actually listen from you what's your input about this topic. I'd like to start with, as you know, the COVID-19 transmission. It is mainly droplet, which means actually it can expand for mostly 6 feet, which is large droplets. Don't need to suspend in the air if inhaled doesn't reach the alveoli, rather than the airborne, which is a very small microns and can reaching actually to the alveoli. So mostly it is droplet and contact infection. The general droplet infections looks like this rain, but when you're going with the procedures with aerosolizations, it looks like this picture, which is a heavy rains. Actually, it is a streaming of heavy rains. So, and despite many safety precautions for healthcare workers worldwide, still they have the possibility to get infected from the COVID-19. And not only in the COVID, even earlier, the data from SARS and the MERS-CoV showing many healthcare workers getting infected. This is our study done in MERS-CoV in Saudi Arabia. It's published actually in PLOS in 2018. It shows 32% of our ICU healthcare workers, not ICU, 32% of the MERS-CoV critical care patients got infected, most of them from ER and from ICU, and which is almost 10% of them. Nurses was 14 out of 32 candidates. Physician was out of 32, and the mortality, hospital mortality was 25% among healthcare workers. And worldwide, until 2 weeks back in Italy, we had 1,000 doctors died from the mainly from generating procedures. And in China, up to February, beginning of February, 17 healthcare workers getting infected, and 6 of them died because of the mainly aerosolized procedures. And this is the first doctor died in Egypt because of generation. Why healthcare workers are high risk for getting infection from the procedures? Because they have always prolonged exposures, because have inadequate hand hygiene, inadequate PPE, insufficient spacing, usually maybe the small side and the small room, and they can actually touching the patient from the near to his head. And one from the very important factor for which is dispersion of air distance, how far the air distance can go, especially during the procedure. This is the most important point. We did find in the meta-analysis systemic review to check the risk of transmission of acute respiratory infection for healthcare worker with the procedure. This is a Canadian study done over 10 study from the 10 publications for in Canada and Singapore and in China. This is late. This is early, not related to COVID. But they found the patient. They did find that the patient with endotracheal intubation have at least 6.5 times more getting infected than the patient who didn't expose to the endotracheal intubation. And they put a list for which procedures have high risk for SARS transmission. This one during SARS. They found tracheal intubation, 6.5 odds ratio, airway care, cardiac resuscitations, still 6 times more chance to be infected, manipulation for BiPAP and non-invasive and mask ventilations, suction before intubation, non-invasive ventilation, manual ventilation before intubation, and collection of the sputum sample. This is the most aerosolized generating procedure based on this meta-analysis systematic review. Let us see how they do that, how they found that. There is actually through simulator lab. Simulator lab, they're putting like a patient, which is, this is a study done to check how far during back mask ventilation, how the dispersion of air during this back mask ventilation. If you can see it here, this is a simulation lab. This is a model like a patient, and this is the green light. It's checking the dispersion of distance of the air dispersion distance during the back mask ventilation. They try to find the two types of the back mask ventilation. One of them, as you know, company Laerdal. The other one is ambu bagging, ambu and Laerdal. But the third one, they tried with ambu bagging, but with here we have a breathing filter, as you can see it in the C. So the first one, back valve mask with a specific company. Second one, another company. The third one, they tried to put a filter here. You can see the green light here. This is the distance of air dispersion. You can see it here. The least air dispersion, you can find it with back valve mask with filter, right? As you can see it in the lower picture here, and you can see it in the other one. So this lights, which is denoting how far the distance. So they calculated, they found it the distance of Laerdal, it is less than the ambu, as you can see it here. And they did try the same scenario with three different types of the healthcare workers, an assist or intensivist handling the back valve mask, the respiratory therapist, the nurse, and the medical student, which trained 2 weeks in the ICU. And they found who can secure the back mask ventilation well. You can see it here. The best is anesthesia and ICU, which is already back mask, ambu back mask with breathing valve, only 13 centimeter distance of air dispersion. Unfortunately, the nurse, they are lacking. They are the most leaking personnel while they are holding the back valve mask. What does it mean? It means you have to connect the filter, as you can see it here, especially in the SARS and COVID and transmitted diseases. And it's better to be in the hand of the experts, like anesthesia or like ICU staffing. PPE by WHO, they recommend while you're going with AGBs performed COVID-19, you have to go with the third level, the highest level of the PPE. We have to go FFP3 mask. FFP3 mask is equal to N99 or N100. This is the same term like European and the American. Double non-sterile gloves, long-sleeved water-resistant gown, goggle or face shield. This is as a general. For any AGBs, you have to go with this level of protection. The most important point, the most important procedure, which is airway management. And you can see many associations, most of them related to the anesthesia, by the way. Most of the association published guidelines for dealing with airway management is related to the anesthesia. As you can find Safe Airway Society, you can find Intensive Care Society, Intensive Care Medicine in the UK, in the US, and the Canada, most of them you have published. Let us go in depth. The last one, which is published early at the end of March, it is European Association. All of them have the same principles. The precautions have to be taken during airway management. You have to be prepared for yourself first and do the plan. Structured briefing is a must. You have to put the plan before you go to the emergency intubations. You have to design your team, assess your equipments. You have to be sure from your plan first. Then, better to be done in negative pressure room. What is recommended to be done in the negative pressure. So once you have a patient with intubation, take him to the negative pressure room. Maximize pre-oxygenation. You can keep your patient at least 5 minutes pre-oxygenation with simple nasal cannula or simple mask or high flow nasal cannula, whatever, and as much as you can, minimizing apnea time, and of course, minimizing back mask ventilation if you can. If intubation is required, it's better to do elective. So early intubation, planned intubation, of course, will be better than emergency intubation. As much as you can minimize the number of the team member in the room. They found 3, it is enough to have handled the patient with intubation. Third level, as stated by WHO, with ABGs. Third level of the BPG. Filter. You have to use filter for every oxygenation interface. Whatever you are using, you have to have filter, bag valve mask, or anything. You have to use filter in between. Rapid sequence intubation in all patients, and limit as much as you can bag mask ventilation. Go with the full dose of muscle relaxants. Don't keep your patient trying to cough or trying actually to straining at any time. It is better to go with the video laryngoscope. First trial has to be video laryngoscope just to minimize, to increase the distance between. Don't come too close to the face of the patient at any time. Early switch to supraglottic airway devices. If you failed in the first trial, go to the supraglottic device early. Even if they failed and you don't have the facilities and you cannot oxygenate, cannot ventilate, better to go surgical cricothyrotomy early, and of course capnograph to assess your tube and your endotracheal intubation. Avoid at any time, at any mean, disconnection of the tube. This is simple. So the Safe Airway Society, they have a very good videos, and we posted in the group actually, and we posted, this is simply how they are doing. They have the best scenario for intubation. You can have the outside, you can have anti-room and the inside room. If you have this facility, it would be very good. They try to close the door to the graft as much as you can. Keep your door of the inside rooms closed all the time. So anti-room, they are preparing in the anti-room everything, donning and doffing, and even there is a runner inside the anti-room. If you can see it here, which can runner 2, which can help in giving the any lacking of any equipments, and the 3 airway operator, as you can see it here on the head of the patients, team leader, which is standing here, and airway assistant is preparing everything. Of course, this is the room of the patient. You can have runner 1 near to the door, or you can have it in the anti-room, runner 2. So this is the best scenario for patients to be intubated. Of course, this red line, which is high COVID, which is level 3 PPE, this is a standard, and here doesn't need to have PPE outside. So this is the best scenario for intubation of the patient. The rapid sequence intubation, I will not, I'm sure all of you know about it, but it's one specific for COVID. They have 4 categories. First one, our airway approach, maximize or optimize the condition to be succeeded in the first trial. This is the best trial you have to go through, because you don't have another chance to intubate your patient. And very expert hands who have to process, and very good precautions with PPE, you have to go through that one. If failed first attempts, don't, as a standard before, we are saying you can try a second and third. This is the standard, but for COVID, no, don't try for that. If the first attempt, you have 2 ways. If you cannot ventilate your patient, or if you cannot oxygenate, you have to go for the surgical airway, cricothyrotomy with bougie assisted. Or if you still can ventilate him, you have 2 plans, plan B and the plan C. Plan B can maintain oxygenation. You have time for another option with very restricted or limited precautions. One further intubation attempt can be done, but you have to have another thing, new things to be done, another expert persons, supraglottic devices, and you have to search for the best. If you don't have a change, proceed for surgical. If they failed of the second one and you can exit, okay. If you cannot exit, go back again to the surgical airway. So the idea behind that, protect yourself, try to be succeeded in the first trial as much as you can. What we have in our ICU, we have this intubation box. This intubation box just to decrease the spreading of aerosolization during the intubation. It has, in many of the ICUs, they tried it, needs some experience to deal with it, and have some limitation, but it's the best way. Many devices just to minimize the aerosolization during intubation in the markets, but what we have this one. And there's a study done, actually, if you can see it, this study, it's shown here. This is the doctor or the physician doing intubation in the simulation lab without intubation box. This is published in NIST, by the way. You can find the dispersion and the patient coughing during intubation. Of course, all of these are simulations. And you can find these droplets on his face mask and then Google in this patient. Once they are using the intubation box here, nothing on his face box. So it means it is protective during intubation by the evidence. Key point for extubation, almost the same like intubation, but some important points. You have to avoid aerosolizations. You have to minimize as much as you can stuff going inside the room to be exposed during extubations. If you can one do the job, would be better. Optimize patient condition to decrease reintubation risk. If you have, for example, criteria for extubation of the normal patient, and sometimes you feel your patient not fitting the criteria and you can't try your clinical experience to extubate him, some of them passing the weaning criteria and would be good, but sometimes you can re-intubate them again. No, don't keep that chance as much as you can for the COVID patient. You have to be sure, almost to be sure 100% that patient will not be re-intubated again. So optimize the condition to decrease the re-intubation risk. Of course, you have to prepare and check all equipment. As we have mentioned earlier in the discussion about the coughing during extubation, you can use lidocaine, you can use dexamethasone, you can use low dose of the narcotics to minimize the coughing during extubation. Protection of the medical team in Wuhan. I'd like actually to share you the Chinese experience. Very, very impressive. Very impressive. You can find that everyone enter any contaminated area, you have category 2. Category 2 in China, it means 2 face masks, 2 medical caps, 2 pair of gloves, 2 pair of the boots, and all of disposable, as you can see in the left side. But if those going for the AGB's areas, so they will add one more, so they have triple cap, triple gown, triple gloves, and triple bulletproof boots. Of course, it was amazing. But you can see it here, some of the procedure they are doing in Wuhan and doing in Shanghai with this intervention. Of course, disposable fiber optic bronchoscope if you are going to the bronchoscope. We have two important, and I want to highlight, and I hope my infection control, I think they are planning to do the same. Two important points: training, hands-on, personal protection training, hands-on, has to be actual in daily basis for all the staff, and body or checkpoints. As you can see it here, one personnel assigned only to just check the donning and the doffing while the physician going out or the nurse going out. This is checkpoint or body, or we can say supervisor. His assignment to review, to check how is the donning of the PPE, and after we finish, how is the doffing of the PPE. So those, you can imagine from February 1 until now, or until March 26, they have 42,000 medical staff was working in Wuhan. With this precaution, they have 0 infection for healthcare workers in the last 2 months. So it was amazing. I'd like to share with you. If you go to the surgical procedure, I think this is your part. And if we have time, I'd like to listen from you. What's your plan if you have the patient coming to you in OR for operations? This is some tips or some points I just want to highlight. Your personal protection is a priority. This, of course, from anesthesia, also patient safety foundation should be managed in a special room for COVID patient, should not be brought. Of course, no waiting area and no post recovery room, either in OR extubated or shift him to ICU to be extubated there to minimize the spreading. The patient should be always wear mask all over the way, in the hallway, inside the room. Regional anesthesia is preferred. Of course, you have to have filters in everywhere in your breathing circuits, antiemetics to avoid coughing and to avoid vomiting, minimize the stuff and hands on. These are some tips. I'm sure you have a plan for such patient if you will go to OR. The CPR, either the UK Council or ALS or ACLS circulations, they published the last month some precautions for the patients with COVID patients while he's arrested. Most of the changes related to nothing related to the medical management or the clinical management of the arrested patient. All of them related to how to protect yourself. First, 3 phases. The phase 1, you have to decide if your patient is DNR or not. If DNR, don't restrict him. And Dr. Rahim mentioned early, the patient how to sometimes you can assess, you can keep him the DNR based on his comorbidity and the severity of index and the criteria. This is the phase 1. So if he's not DNR, you need to proceed. The assessment of consciousness level or unresponsive or not, or assessing of rhythm, you need to have phase 2, which is the level of PPE, level 2 PPE. So assessment of arrested patient, you have to wear disposable gloves, you have to wear disposable apron, you have to FFP2 or 95 or disposable eye protection. So you have to complete wearing PPE. If you are going to the resuscitation, CPR in the phase 3, so phase 3 AGB's protection PPE, either shock, of course, with paddles or with CPR. So chest compressions don't do without complete protection of the PPE, which is labeled as the phase 3. There's some UK have some sort of comment. Chest compression is not AGBs. No, most of the recommendations saying it is AGBs. You have to protect yourself fully with the AGBs. The ALS, so they have some sort of stop anyone doing CPR before donning. Don't put your face near any patient face. Don't start chest compression unless you are in full PPE. Appoint a gatekeeper, a body or a person who can check full PPE for the staff. And to improve the quality of the performance, you have to have a debriefing after you will finish. Circulation published early of this April the guidelines for SLS highlighting almost the same. Reduced provider exposure, the main 3 important points: reduce provider exposure, prioritize oxygenation, and decreasing the apneic oxygenation. And you have to address goal of care for the patients. So almost we have the same principles. If you are going to deal with patients with oxygen therapy, there's some precautions you have to take. If you are planning to use non-invasive support, use double-limbed circuits. Don't use one circuit. And keep filter in each space. 3 filter, 1 in expiratory limb, 1 in inspiratory limb near the machine, and 1 close to the tube, close to the face mask of the patient. Which type of non-invasive? Nasal or face mask or whole face mask or helmet? Let us see this. We can solve. This is the whole face mask on the right side. Again in simulation lab, and the patient non-invasive ventilation. This is the left side helmet, but without neck cushion, without support of the neck, without inflator cushion here. In the middle one, helmet with cushion. This using this one in Italy nowadays. You can see the dispersion of air with the whole face mask from the front piece here of the mask reaching to 1 meter almost. So total face mask is not recommended. Using helmet without cushion of the neck, spreading can be up to 27 centimeters. You can see it is the green one from the leaking here and the neck side. But with cushion, with inflatable cushion, closing, tight sealing around the neck, almost you have negligible air dispersion. So we're talking about non-invasive, and Italian people using this one nowadays for non-invasive ventilation. Okay, so non-invasive almost try to avoid with simple face mask or nasal mask. Using a high flow nasal cannula, yes, you can use it, maximum 60 ml, 60 liters per minute, but be sure that is completely secured in the nostril, and you can use surgical mask on top of the nasal cannula for the patient himself. Back valve mask, we said the precaution of the back valve mask, put filter, as we have mentioned early, near the patient, use closed circuit in case of suction is needed. Don't use open suction for such case. Bronchoscope, as much as you can, try to avoid it. Try to avoid bronchoscope unless indicated. When you use it, level 3 BB, high aerosolizations. Keep continuous suction inside the mouth. They found this continuous suction decreasing the aerosolization and the distance by coughing by 30%. So continuous, not intermittent. And have surgical mask, cover the patient with the surgical mask. Place suction catheter, keep it continuously, and shower is recommended, of course, for the staff. So this is the precaution for bronchoscope. And as we have mentioned earlier, it's better to be avoided as much as you can. Right? So the keynote, I think, is my opinion. What makes difference between mortality between different nations? Your strictly infection control measurements, apart from national protection rules and national resources, of course. So please, safety is something very essential for the staff, for the community, and for all of us. And I hope all of you to be stay safe and pray. And thank you so much. I can receive the questions until we'll proceed. Sorry, we take almost a few minutes more long. Chat room. I can't open my chat room. Are we using nitric oxide inhalation? And what about phosphodiesterase inhibitor 5 inhibitor in ARDS? Okay, this question actually for ARDS, Dr. Ibrahim, Dr. Dr. Ibrahim, Dr. Omar, if they likes to answer, or I can. Nitric oxide as a general for this doesn't show benefit, but I can disclose in the early stage of the pulmonary hypoxic pulmonary vasoconstriction, early phase of the COVID ARDS, they have some studies showing little, they can use it with pulmonary vasodilators. So there is a space for the clinical trials for some research for pulmonary vasodilators, as well as nitric oxide in the early phosphodiesterase inhibitor, prostacyclin, whatever, or nitric oxide. Any more questions? Any studies that aerosol producing procedures have caused disease? If yes, how much risk? Oh, I can disclose most of the people died, the 6 physicians died in China, reported in February 11, they exposed to intubation with many times without protection with high viral load. They found that for themselves. So aerosolized generating procedures is highly risk for transmission of the infection. Great. So all of us want to be safe as well as you. So kindly, you have to follow the protection, and I hope the institution will help us actually to give us. What is about fiber optic? Not recommended. Not recommended at all. Fiber optic. Any aerosolized procedure not recommended. As I'm saying, inshallah, you will mostly, we hope we will not need your support. It will be bus safely, but I want to say your experience in airway management is better than us. So inshallah, as intensivist and as an assist, all of you, we are relying on your experience in dealing with the procedures. Right? There is a question which is better for mask ventilation, use a face mask. There is a question which is better for mask ventilation, usual face mask or anything. Mask ventilation is better to avoid. Back mask ventilation, if you mean, it's better to avoid it as much as you can. But if you need it, actually, you know, even the way they are mentioning, all of us know the C and E for holding the back mask ventilation. Right? They change it for the respiratory, for the SARS, for the COVID patients to be V and D because they want to control your tight seal. So don't hold the mask like that. Hold it like this. You can have a good hand grip on the inflatable points of the mask with the cheek. So to be sure that the patient is the tight seal without any leaking. And of course, don't forget the filter. Don't forget the filter. Is it a must to send the ventilator after the procedure to the CSCD? I can, Dr. Thamer, I can, for the ventilator of the OR. We are not doing that. We have, every company or every manufacturing have their own guidelines for disinfection of the devices. This is for everything, even the fiber optic, the instruments, and our respiratory therapists, they are the one handling the cleaning of our ventilators. So I think we can refer to the manufacturer, and we can refer to the CSSD department. And but to send them routinely after OR for each patient, I don't think so. There is specific precautions. It is more safe to avoid extubation post-operative for positive case. Dr. Ibrahim, yes. Don't to avoid extubation. I want to say, if you are planning to extubate him and he's fully recovered, better to be inside OR and the specific designated room for COVID patient inside OR, almost. If you don't have that chance, don't put him in the recovery room. Either to extubate him inside OR with negative pressure room with full precautions, with very good criteria for extubation, or shift him to ICU to be extubated there. Right? So, and that, by the way, we are teamwork. Maybe your colleague will be in our ICU during that time, so we're not sliding the case to each other. Okay. which type of the filter you are using in your breathing circuits. HME, this is what we are using, and it's bacterial and viral filter. What about transfer of COVID positive patient? Oh, yes, this is actually another big dilemma. Transportation of the COVID patient either from one area to the another area or from an area by the ambulance to other hospital. This is a specific lecture for that, but the same precautions, the same. Alhamdulillah, we have now the capsule. We have our own capsule, right? This capsule, you can transfer the patient of COVID patient from OR to the ICU or ICU to OR or anywhere inside the hospital, inside the COVID capsule, specific for COVID patients. It is safe to shift intubation patient to the ICU by ambu bagging because of lack of portable ventilators. It is safe to shift intubated patients. It means COVID patients, right, to ICU by ambu bagging because of lack of the portable ventilator. Really risky, really risky. But what we can do, we can have filter. We can clearly have deeply sedated patients. We can have be sure that the cuff is inflated very well. We can have the face shield, or we can have a drap over the patient who is negative to secure any dispersion of the air. But this is in circumstances you don't have the facility. But if you have, will be better. Do you use patient capsule in the CT or MRI? Actually, we are not doing CT or MRI for the patient of COVID currently, unless indicated, highly indicated. Because what I was so told that ICU staff refusing that, I mean, shifting patient with ambu bagging. Ambu bagging is different with closed circuit ambu bagging with the tube rather than bag valve mask. Ambu bagging, portable ventilator, we have many portable ventilators. It will be more safe. Many portable ventilators would be more safe. But I'm saying in very critical situation, if you don't have portable ventilators, you have to take all the precautions. We take long time. Patients during upper GI endoscope. Should we intubate all patients during upper GI endoscope? COVID patient, yes. Don't do any procedures close to the airway. Patient has coughing, to spread coughing at any time without securing closed circuit airway. Of course, has to be emergency procedures, not elective procedure. Thank you so much. Really, I appreciate it. Still, we have more. Time is passing, Shabab, still have. So now I'd like at the end to thank you, all of you, for presence with us. Thank you so much for having all of this time with us in this course. And I'd like to thank all my guest speakers, all my colleagues, all my friends, as well as my very hard worker, two coordinators, Dr. Gultakin and Dr. Ahmed Kuhail, as well as Christine and Amy, the course coordinators. Dr. Ahmed now, he will just explain to you how we can proceed through the MSQ session, right? Dr. Ahmed.
Assalamu alaikum. So we'll send now the link here and in the groups. It will be 40 questions. In addition to that, you have to write your name and the hospital, which hospital you are. This is 40 questions. It will be for 40 minutes. After that, we will close the link. The pass rate, actually, it's 50%. You should exceed the answer at least 20 questions correctly to get the certificate of attendance of this course. So now we will send the link. Good luck. Thank you for joining us.
Thank you so much. Thank you, Gultakin.
Good morning, everyone. Thank you, Dr. Mahdi. And thank you all the speakers. Thank you, Dr. Ahmed Kouhail and our sister Christine and Emily. And thank you for all the participants to participate in our course. And I wish you all the best and hope you get much information and much benefit from this course. And again, I wish you all the best and hope we may not need you in our work time as as this pandemic will finish fast. And all the best again. Thank you.